See something? Okay. It's the process which we receive, we organize, and interpret sensation. It's our perception. Okay. Um, now I have this. That's it. It affects your hearing. It's age-related hearing loss. Okay. All right. What about paresthesia? That's an easy one. Yeah, abnormal sensation, right? Typically, what do they complain of? Prickling at the bottom of their feet, right? Pins and needles is caused by pressure on or damage to peripheral nerves. Okay? Okay. Tinnitus. What is tinnitus? If you give Lasix too fast, what will that patient complain of? Tinnitus. Okay, or buzzing in your ear. Have anybody ever had diplopia? Double vision. No, I've had that. Well, let me tell y'all. All right. So, with neuropathy, the book really does not have anything, your MedSurg book. So, if you will use this book, okay, on page 352. But neuropathy is pretty cut and dry, isn't it? Right? Page 352, 353 in your review book. Both. No. All you have to do, you saw what we just did in our activity. That's all you have to do, and just know the name of it. Okay? And that's it. All right, so neuropathy. What is going on with neuropathy? Nerve damage. What do they complain of? Burning, pins, prickly, tingling. Right. Is there a lot you can do for it? No. What do we usually give them for medicine? Gabapentin or Neurontin. Okay. So what do you think some safety issues that you need to teach your patient about neuropathy? Always, 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 what do they need to do? Wear shoes. They've always got to wear shoes. Before they get in any water, what should they do? Test the water, right? Prior to showering, getting in a hot tub, anything like that. Do they really need to be in a hot tub? No, they really don't. What about smoking? Is that an issue? They need to stop. They need to decrease their smoking. They need to, if they qualify, if they are a smoker, they need to get into a class, right? A cessation class. If they are a liability or risk for falls, what do you want to teach them to use? Well, the walkers. Walkers. Let's say they're bedridden. What is something we can put on their bed that can help decrease the pressure off of the sheets or blankets? You can. You can do that, or a cradle over the bed, at the foot of the bed. You can do that. But we definitely do not want to walk barefooted. Okay. If the patient is incontinent, we need to be careful with our cleaning supplies. Does that make sense? That would break down skin, especially if they can't feel their feet. What else, other kind of teachings do we want them to do? Exercise. We still want them to continue to do mild exercising 3 times a week, right? For at least how many minutes? 30, right. With their feet, what's very important that they need to do every day? Inspect it. Yeah, inspect it. And then of course, if they start gabapentin today, is that going to stop that pain today? No, what does it have to do? It has to build up. So they don't need to just take it when they have pain, right? They need to take it every day. Let's see. They could possibly get a TENS unit. Do y'all know what that is? Have y'all gone over that? Okay. Well, it's like a electrical nerve stimulation device. It has to be prescribed by the doctor. And again, teach them about alcohol intake and moderation, because we don't want them intoxicated, right? Because that can worsen the peripheral neuropathy. Okay. And again, it's page 352 and 353. Okay. Know your teachings. All right. Let's now go over. Do y'all know anybody who's ever had a cataract? Yeah. So the definition is a lens covering. It's like a white covering of opacity that distorts the image. Okay. As people age, the lens gradually loses water and increases in density. Both eyes may have a cataract, but at the rate of progression, lens density increases with drying and compression of older lens fibers and production of new fibers and lens crystals. Now, both eyes may have cataracts, but at the rate of progression, it is different in each eye. So they might come in this month and they'll have a cataract removed, and they might wait 6 months, come back in, and have the next cataract removed. Okay? It can be present at birth, or it can develop over time, and like age, may be age related, or it can be caused by trauma or exposure to toxic agents. So if you look on page numbers 939, you'll see some causes, okay? Causes. Table 42.4, and it can be age, it can be blunt trauma to the eye or head, a penetrating eye injury, foreign body in the eye, radiation exposure. It could be from using corticosteroids, prolonged use. Diabetes can cause it, hypoparathyroidism, Down syndrome, chronic sunlight exposure. So those are some but we're going to break it down even more. But cataracts occur earlier with heavy what? Sun. So if you're outside, what do you need to be wearing? Sunglasses, yeah. Or exposure to other sources of ultraviolet light. Give me an example of that. Tan in bed, and in the tan in bed, what do they give you? Those little skinny eyeglasses, right? Do y'all wear them if you get in them? Y'all don't? Y'all need to. But first of all, you don't need to be getting in no tan in bed. Okay. All right, so we're going to wear sunglasses. We're going to urge adults to wear what type of protection? Eye and head. Eye and head protection during sports, baseball, or any activity that increases the risk for the eye being hit. Now, individuals who, guess what? Smoke are at higher risk for developing cataracts versus non-smokers. So, our assessment, we're going to ask their history, okay? Have they had any recent or past trauma to the eye? Have they been exposed to radioactive materials like x-rays? Do they work in x-ray and don't check their little badge? Or UV light? Prolonged use of steroids, corticosteroids, beta blockers, chlorpromazine, that puts you at risk. We want to find out, do they have a presence of intraocular disease? Intraocular disease. We also want to ask them about their systemic diseases like diabetes, hypoparathyroidism, hypertension. We want to find out, have they had a previous cataract? Do you have a family history of cataracts? And do they smoke? You want to ask the patient to describe his or her vision. What can you see well, and what do you have difficulty seeing? So our signs and symptoms of cataract. You will have slightly blurred vision, decreased color perception. As cloudiness continues, blurred and or double vision. What cranial nerve was that? 10. She gets bonus points. Air, 2. Double vision occurs, and the patient will have difficulty with their, what are ADLs? Activities of daily living. They will need to report trouble seeing at night, especially while driving. I'm telling you, if y'all are going through this, y'all are like, I got this. Personally. Without surgery, guess what it will lead to? Blindness. Yes. Now, with cataracts, there is no pain. No pain or eye redness is associated with age-related cataract formation. So our psychosocial assessment, loss of vision is gradual and may not be aware of it until reading or driving is affected. So you want to encourage the patient and family to express concerns about reduced vision. So intervention. What is the only way to cure this? Surgery is the only treatment to treat cataracts, and it should be performed as soon as possible after vision is reduced and ADLs are affected. So we have set them up for surgery. Their cataract is ripe. Have y'all ever heard of that? So I promise y'all, I do have a cataract, but it's still growing. Isn't that scary? So when it gets ripe, then they'll be able to take it out. All right, so teaching. So this is what you want to teach your patient, okay? Care before and after surgery requires regular self-examinations of the eye and installation of different types of eye drops several times a day for 2 to 4 weeks. You'll need to ask the ophthalmologist whether there is a need or lack of need to use them before procedure. If the patient is unable to instill the drops, him or her will help him or her make arrangements for this care by asking a friend, family, or a neighbor. They also have this thing, it's an adaptive equipment that position the bottle of eye drops directly over the eye, and that can be purchased. You want to ask whether the patient takes any drugs that affect blood clotting, like aspirin, warfarin, the C word, which is really, what is it, Plavix, and dabigatran. I'm not sure what that one is. You want to ask the surgeon because some of these drugs may need to be discontinued before cataract surgery. A series of ophthalmic that the eye drops are instilled just before surgery to dilate the pupils and cause vasoconstrictions. Others will cause paralysis and prevent the lens movement. In the surgical area, a local anesthetic is injected into the muscle cone behind the eye for anesthesia and eye paralysis. So that's pre-op. During surgery, well, actually it's going to be after, but some patients will have distant vision restored to 20/20 and may need glasses only for reading and close work. Immediately after surgery, they will be given antibiotic and steroid drops, or ointments. Ointments are instilled. Discharged within an hour after surgery, after stabilization and monitoring. So usually they have like a MAC anesthesia, so they're sort of awake, sort of not, but they will not remember anything. So they come back the same day. You get vitals, you give them something to drink, usually a Diet Coke or coffee. They say, okay, I gotta pee. Take them to pee, they pee, out the door they go. And that's it for same day. So teaching. We want to instruct him or her to wear what color glasses? Dark. Outside. Have y'all ever seen someone leave surgery or they just had cataract surgery? What are they wearing? Them big black plastic sunglasses. Y'all know what I'm talking about? They come here and here, they're huge. So you have to tell them to wear their dark sunglasses until the pupil responds to light. You want to teach the patient and family members how to instill the prescribed eye drops. Help the patient family create a written schedule for the timing and order of eye drops administration, because it's like every couple of hours they're having to instill eye drops, okay? Remind the patient that vision in the eye will be blurred and not to drive or operate heavy machinery until the ointment is removed. They have to keep all follow-up appointments, okay? You're going to remind the patient that eye itching and bloodshot appearance is what? Normal. Eye itching and bloodshot appearance is normal. Now the eyelid may be slightly swollen. Now if they have significant swelling or bruising, that is abnormal. But slightly swollen is okay, but lots of swelling or bruising is not okay. We can tell them they can apply cool compresses, can be beneficial. Discomfort at the site is controlled with Tylenol or acetaminophen. That Tylenol generic name starts with an A, okay? Or they can have Tylenol number 3, okay, as prescribed. What can they not have? Aspirin. No aspirin, okay? Oh, sorry. No aspirin. Early pain after surgery may indicate increased intraocular pressure or hemorrhage. So if they have that, you want to instruct the patients to contact the surgeon if pain occurs with any nausea and vomiting following with the pain. Okay? They need to avoid getting water in the eye for 3 to 7 days after surgery. They can cook and do light housekeeping, but not vacuuming. And they refrain from driving until vision is clear. Now on page 942, the little box here, it says the patient after cataract surgery. Just read over those and basically a lot of it. Okay. Now, to prevent increases in intraocular pressure, you want to teach the family and patient about activity restrictions. So on page 941, table 42.5, it talks about activities that increase intraocular pressure. That's like bending at the waist, lifting objects more than 10 pounds, sneezing, coughing, blowing the nose, straining to have a bowel movement, vomiting, sexual intercourse, keeping the head in a dependent position, or wearing tight shirt collars. Those will increase your intraocular pressure. So after cataract surgery, you do not want to do any of a lot of that stuff until the doctor tells you you can, okay? All right. To prevent infection, you want to teach the family and patient to observe for increasing eye redness. Now, can they have bloodshot appearance? Yes. But if they have redness, increasing redness, decrease in vision, increase in tears, and photophobia, what do they need to do? Contact the HCP. Yes. It says increasing redness, more like solid. You know, bloodshot can be like yeah, it's like really like, have you ever seen like hemorrhage inside somebody's? That would be like that. That's not good. That's not right. Right after cataract surgery. But if they have a decrease in their vision with it, or tears, or the light bothers it, they need to call the doctor. If they have green or yellow, skip down past creamy, but if they have yellow, green drainage, that's going to indicate what? Infection. But if they have creamy white, dry, crusty drainage on the eyelids and lashes, that is normal. But what is abnormal? Green and yellow. If they have that, what are they leading toward? An infection. So that leads us to stressing the importance of what? Hand washing. So patients usually experience a dramatic improvement in vision within a day of surgery. The final best vision will not occur until 4 to 6 weeks after surgery. So post-op instructions. We have to adhere to the eye drop regimen after surgery. And what is that regimen? Time to instill what? Eye drops, right? You have to follow that regimen. You don't get off of it. You want to provide patient or family with accurate information and demonstration of skills. You want to review complications with patient and family to report. So if they have sharp, sudden pain in the eye, bleeding or increased discharge, increased discharge from the eye, green or yellow thick drainage from the eye, the eyelid swelling, not just your little swelling, but it would be like significant swelling of the eye, reappearance of bloodshot sclera after the initial appearance has cleared. Because in the beginning, is bloodshot normal? Yes. But after that goes away, but it comes back, that's abnormal. If we have a decreased vision in the eye that had surgery, and then if they have flashes of light or floating shape seen in the eye, we have to call the doctor. Okay? All right, let's move to glaucoma. Glaucoma is a group of eye disorders resulting in increased intraocular pressure. Do y'all know anybody that has glaucoma? Yeah? Well, I'm a suspect. So we're going to hear what I have to do in a little bit. So for proper eye function, the gel, this is just some patho. For proper eye function, the gel in the posterior segment and the gel in the anterior segment must be present in set amounts that apply pressure inside the eye to keep it ball shaped. Adults, the volume of the vitreous humor does not change. Usually about 1 ml of aqueous humor is always present, but is continuously made and reabsorbed at the rate of about 5 milliliters a day. A normal intraocular pressure, or IOP, requires a balance between production and outflow of aqueous humor. If the IOP becomes too high, the extra pressure compresses retinal blood vessels and photoreceptors and their synapsing nerve fibers. This compression results in poorly oxygenated photoreceptors and nerve fibers. These sensitive nerve tissues become ischemic, and guess what they do? Die. When too many have died, vision is lost permanently. If untreated, glaucoma can lead to complete loss of visual sensory perception. Glaucoma is painless, and the patient may be unaware of the gradual visual reduction. So on page 942, table 42.6 is your causes of glaucoma. Okay, it's usually primary, secondary, or associated. So our primary cause is aging and hereditary. Associated would be like if they have diabetes, hypertension, retinal detachment. And then secondary will be like trauma, tumors, ocular tumors, eye surgery, degenerative disease. And y'all can read over that. Okay? But the most common is what? Primary. Primary. And the most common of primary glaucoma is primary open angle glaucoma, POAG. It usually affects both eyes and has no signs or symptoms in the early stages. It develops slowly with gradual loss of visual fields that may go unnoticed because central vision at first is unaffected. Our vision is foggy with mild eye aching or headaches. Now the late signs, they occur after irreversible damage to the optic nerve function and include seeing halos around lights, losing peripheral vision, and decreased visual sensory perception that does not improve with eyeglasses. Because the fluid cannot leave the eye at the same rate that it is produced, intraocular pressure gradually what? Increases. It increases. Primary angle closure glaucoma, PACG, or acute glaucoma, this is sudden, a sudden emergency. It's like a sudden onset. And symptoms include sudden visual loss, pain, conjunctival asthenia, corneal edema, and glaucoma is a common cause of blindness in North America, and it's age-related. There is no known ways to prevent glaucoma. So, the best prevention against damage is that glaucoma can cause is for adults to have an eye examination with glaucoma checks done every 2 to 4 years before the age of 40, every 1 to 3 years between 40 and 54, every 1 to 2 years between 55 and 64, and every 6 to 12 months for over age 65. So what do we want to do as nurses? We want to ask their history. So we ask about visual symptoms that have developed suddenly or over time. Our physical examination or assessment, signs and symptoms, the examination shows cupping and atrophy of the optic disc. It becomes wider and deeper and turns white or gray. And the sclera may appear reddened and the cornea is foggy. The diagnostic, how they test diagnostically, is an elevated intraocular pressure is measured by the y'all ever had that thing? It's that pen thing that they numb your eye and they like touch, looks like a pen and it touches your eyeball. Yeah. I don't know about a puffer, but I know they'll just like stick it in and test it. Yeah, I don't either. In open angle glaucoma, the reading is between 22 to 32, and the normal is 10 to 20. In angle closure glaucoma, the reading may be 30 or higher. Visual field testing is performed and is visualization by this little scope to determine whether the angle is open or closed. Have y'all ever stuck your head in that thing? It looks like a, you know that dryer that old people sit under? Old people? It has all them holes in it. Y'all know what I'm talking about? Alright, so that goes over your head. Like old people use it to set their hair. Oh, y'all have it? Oh, yeah. Okay. Alright, so, well, y'all not old. Alright, you flip that thing over. Flip that hood hair dryer over. I just remember my grandma using it. That's what I can relate it to. Alright, so you have that hood and flip it over. You put your head in it, and they give you this little clicker. Have any of y'all ever had to do this? Well, no. It's dots. It's dots. Like you stick your head in, and every time you see the thing, the light come through, you have to hit it. Yeah, so that's another way of testing. That's this visual field testing. All right, so the optic nerve is imaged and to determine to what degree nerve damage is present. All right, so supporting. With proper interventions, the patient is expected to maintain optimal visual acuity as long as possible by adhering to the treatment regimen. So this is what we're going to teach them, okay? Loss of the visual sensory perception from glaucoma can be prevented by early detection, lifelong treatment, and close monitoring. They'll use ophthalmic drugs that reduce ocular pressure and can delay to prevent damage. All right, going off subject, this is not on the test, this is not on NCLEX, but what else can they give you to decrease your ocular pressure? Weed. Gummies. Cannabis. Yes. Did y'all know that? It's not in your book, but that's real life, right? No, I've never. I'm not there yet. I'm not there yet. I'll come back. No, I'm not on weed. No. Never have. I'm going to get there. Okay. All right, so we're going to teach the patient to be dedicated at regular timing of administration. You have to teach the patient that the benefits of drug therapy occurs only when the drugs are used on the prescribed schedule. Patients must instill drops on time and do not skip doses. You have to wait 5 to 10 minutes between the drugs installations to prevent one drug from diluting another drug. You've got to stress good hand washing, keeping the eye drop container tip clean, avoiding touching the tip to any part of the eye. Teach the technique of punctual occlusion. Okay, do y'all know what that is? It's when you're placing pressure on the corner of the eye near the nose. And on figure 4218, page 946, it's a picture of a person doing this. Okay? Immediately after the eye drop installation to prevent systemic absorption of the drug. So we call that what? Punctual occlusion. And what are we doing with punctual occlusion? You're pushing in right there at the corner of the eye as soon as you put the eye drop in. Eye drop in, do your punctual occlusion, and what's the purpose of it? Very good. Very good. All right, drug therapy. It works to reduce IOP in several ways. It reduces the production or increase the absorption of aqueous humor or constrict the pupil so that the ciliary muscle is contracted. The drugs do not improve lost vision, but prevent further damage by decreasing the IOP. Most eye drops cause tearing, mild burning, blurred vision, and a reddened sclera for a few minutes after instilling the drug. Now, if the drugs, eye drops, stop working, oh yeah, y'all sure can. Holler out the door. We seniors, we get to do what we want, right? All right. So, surgical management performed when drugs for open angle glaucoma are not effective at controlling IOP. They can try a laser, which burns the trabecular meshwork, scarring it and causing the meshwork fibers to tighten. If that doesn't work, they can do a trabeculotomy, which creates a new channel for fluid outflow. A failure to respond to common approaches, an implanted shunt may be used. Complications from that, though, include hemorrhage and detachment. Hemorrhage and detachment. Choroidal hemorrhage and choroidal detachment. However you say it. And that can occur when someone, during or after sneezing, coughing, straining at stools, or the Valsalva maneuver. Serious detachment involves some degree of vision loss, which is painless. Loss, painless. Hemorrhage detachment is an immediate loss of vision with sudden, excruciating, throbbing pain. And if they have that, what do we have to do? Notify the doctor. All right. Know this. Put y'all some stars by these two names, okay? Page 944. You see this promote the living, promote dependent living, independent living. So let's talk about this. A patient with impaired vision. What are some things you would like to do for them? If you're taking care of them, they have difficulty seeing. Give me some things that you would do. Do you rearrange their furniture? No, because they know where. Huh? Right. Take away rugs. Do not rearrange their furniture. With their food, what can we do? A clock. Right. A clock, and tell them where you have placed everything, right? When you walk into the room, do you just come straight in? What do you say? I'm coming in. It's Pam. I'm coming in. Come on in. All right. What are some other things we could do? Right. Let them know, hey, I'm fixing to take your blood pressure, or I'm fixing to give you an injection, or whatever. I'm fixing to touch you. Right. You can orient them to places and time, because if they're blind, can they see time? A clock? No. All right, what are some things that promote seeing that we could do? Like books. What type of books do they need? Large print, right. How many of y'all have already moved up to the large print Bible? Large print planner. All right, what about telephones? What do they need? Numbers, large numbers, okay? Yeah, a big remote, okay? If they have difficulty. All right, also go to page 945. 945, know your drugs. Just like read over them, okay? Because they're given like beta blockers, prostaglandin. So just read over that whole little common examples of drug therapy, eye drops, okay? All right, do y'all need a break? We only have 2 more things to go over. Well, that's just you. Just hang tight. Break. All right, take a little break. Degeneration. Yeah. Degeneration. Yeah, I misspelled it on the top one up there. Do y'all know anybody who has that? No? Okay. I know somebody, but anyway. All right, known as age-related macular degeneration, AMD, is a deterioration of the macula, which is area of the central vision. It can be age-related or exudative. It's the leading cause of blindness in Americans 65 years of age or older. There are two different types. Now, have y'all seen the commercials on TV? This is the commercial, and it's that eye, and she goes, opens it up and walks through that eyeball. Okay. All right. Well, that's a commercial. Okay. The dry AMD is more common type is caused by a slow and gradual blockage of the retinal capillaries and pigmented residue and photoreceptor waste products in the retina. This allows retinal cells in the macula to become ischemic and necrotic. The central vision declines, and the patient complains of mild blurring and distortion at first. Night vision is impacted, and the ability to see clearly when reading is impaired. Eventually, the patient loses all central vision, and it progresses at a faster rate among who? Who do y'all think? Smokers than non-smokers. Risk factors that can lead a person into the AMD: diabetes, hypertension, high cholesterol, being over the age of 60 years old, Caucasian, and a family history of AMD. That's dry AMD. Now, wet AMD, it progresses quickly. Patients experience a sudden decrease in vision after a detachment of pigment epithelium in the macula. Newly formed blood vessels, which have very thin walls, invade this injured area and cause fluid and blood to collect under the macula, just like a blister. That sounds painful, doesn't it? With scar formation and visual distortion. This can occur at any age, in one eye or both eyes. The patient with dry AMD can also develop wet AMD macula. So the assessment. An eye care provider will likely conduct indirect ophthalmoscope to assess for gross macular changes, opacities, retinal concerns, and hemorrhage. Retinal and hemorrhage. IV fluorescein angiography may be performed by the eye care provider to locate leaking vessels. And they may use this grid test to demonstrate central vision field loss. So interventions for dry AMD, there is no cure. No cure. You have to focus on slowing the progression of the vision loss and helping the patient maximize remaining vision for the quality of life. Risk can be reduced by increasing long-term dietary intake of the carotenoids, lutein and zeaxanthin. Keratin. CAROTENOID '. I'll spell it again. CAROTENOID'. Central vision loss reduces the ability to read, write, recognize safety hazards, and drive. So you want to suggest that they get large print books, public transportation, and they refer to community resources to provide adaptive equipment. So if a person who lives alone, they live alone, they have this, they can't drive at night, they have trouble getting around, who can they call to get their food? Meals on Wheels? DoorDash? Well, yeah, it is. Yeah. Yeah, it's just not made it to the books yet. The book says Meals on Wheels, but yeah, DoorDash and yeah, takeout, right? All right, wet AMD. It involves slowing the process and identifying further changes in visual perception. Fluid and blood may reabsorb in some patients. Laser therapy is used to seal the leaking blood vessels and can limit the extent damage. Ocular injections. Ugh, that sounds painful, doesn't it? Injections with a vascular endothelial growth factor. What now? I don't know. It didn't say. It did not say. So I think the dry is the most common, and that's actually the one that commercial is about. But the wet, they seem like they're a hot mess. Like it just hits them. Versus the dry, which gradually is age-related. All right, so we already know cataracts. That's blurry, can't drive at night. Glaucomas are peripheral, right? What's macro? Macular. Right. You can see on the side, but if you look straight ahead, you're not going to see anything, right? Okay. All right, those are the eyeballs. Meniere's, what are we dealing with there? Dizziness. So the classic trio symptoms, you have vertigo, tinnitus, and hearing loss. Vertigo, tinnitus, and hearing loss. These episodes, called attacks, can last several days. Some patients report ongoing symptoms of varying intensity at all times. Patients can almost be totally incapacitated. Don't put that on my eval. I know I can't pronounce, okay? I know that. Y'all know it, I know it. During an attack and recovery can take hours to days. Most patients have a window of forewarning, and when the attack is beginning, others experience a marked otolytic crisis. It's known as sudden drop in attacks. They might hit the floor, in which the patient falls to the ground with no warning. Okay? Meniere's disease is progressive. It's leading to an excess of endolymphatic fluid that builds up within the inner ear, causing this discoloration and distension of portions of that L-word system. This distortion decreases hearing by dilating the cochlear duct, causes vertigo because of the damage of the vestibular system, and stimulates tinnitus. At first, the hearing loss is reversible, but repeated damage to the cochlear from increased fluid pressure can lead to permanent hearing loss. So, it is okay. And these will read. I'll see that pink. That's Meniere's. Okay, 968. So symptoms, vertigo, hearing loss, and what? Tinnitus. So vertigo is accompanied by vomiting,
What's going on?
headache,
Not much.
nystagmus. What's that? Nystagmus?
How many babies you got?
10.
Moving on up, ain't you?
Blood pressure, pulse, and respiration.
Was this Miss Chelsea, this Miss LaToya? She's our future RN in 2 months.
Good
home.
Yes, ma'am. All levels and including
Yeah, so today is the 10th.
Patients
So-
may describe tinnitus as
having
We're
a variable
expecting Sandra
pitch,
Clinton tonight from
intensity, and may
11:30 to 8 for
fluctuate or
Coming in on the
remain
10th tonight, she's expecting Lakeisha Thornton, Reed
Interventions.
Wilkerson, and right now, this is
diet
Latoya Rice.
and
Okay.
So in the morning, she's
In
expecting
some patients,
Jessica
resistance
Wansley.
to triggers
And what's going on?
salt,
You 2 hours,
Yes, ma'am.
Okay.
For an appointment.
2 hours, what now?
For an appointment.
Okay. What type of leave? FMLA?
Yes, ma'am.
alcohol,
The sick leave, FMLA.
stress,
7:30 to 9.
stress, and allergies.
Okay.
So salt, caffeine, alcohol, stress are the four points.
Okay.
So what are we going to teach them?
I have
How
that
to
down.
modify their diet. What type of diet?
Okay. What did we decide?
Low
For telemetry.
sodium, right? And also
them
making
to the
sure that
To the floor.
Yep.
Because we got the 2 rooms, because Rashawn is not coming in. Thank you, Miss Latoya.
Yes, ma'am.
Bunny,
Oh, did I put you down? I didn't mark you down from this morning. I don't think I
avoid
came in here other
activities
than
that
the
put them at
holiday
risk
week.
of experiencing vertigo, like standing on
Okay,
ladders.
today is,
Do they need to be standing on
Yes.
ladders or standing on chairs? No, because of what? That's sudden drop to the ground, right? Patients with sudden drop attacks should not drive. You want to teach the patients to move their hips slowly to vertigo. Institute and teach fall precautions. And then you want to use exercise activities to improve balance. And the last little part, our treatment. They will be given beta-histine or diuretics. Vestibular supplements and antiemetics. That can be used to address symptoms that may occur during the attacks. Not responding to the pharmacologic interventions, systemic glucocorticoids may be used. If they are used, if they fail, glucocorticoids fail, y'all can read the rest of it. Yep. Alright, so if drug therapy is not effective in controlling symptoms or attacks, decompression and or shutting of the endolymphatic sac, it is shown to have favorable outcomes in controlling vertigo. They will have a, can be done in extreme cases in which the patient already has significant hearing loss or continuous disabling vertigo. So mainly with Meniere's disease, what's our main thing? Fall risk, safety, diet, getting rid of your other risk factors, right? Okay? Alright. Alright, y'all wanna do your thing together? Okay. Alright, so get your case studies. Case studies. I handed it out first. We're almost through, y'all, I promise. I promise. And we still got the fun thing to do. What?
It's because we come at
I know, y'all. I know. Come on, let's do it together. Quit rolling your eyes. Come on. Oh, yeah. Alright, y'all ready? Would y'all rather just do it at your house? Okay. 1 to I know, exactly. All right, so Ashley, will you read the case study?
Although he has attempted to stop smoking on several occasions, he wears a hearing aid each year to put the hearing loss and the book working. Robert presents for a routine frequency of nerve he does not seem satisfied. Nerve practitioner believes Robert seems to stop and already takes good for his nerves on the bottom. Robert is surprised that he is unaware and asked about whether it makes Robert did not reply. Robert brings the date. She asked that he knows
Alright, so what approaches could be used to maximize effective verbal communication, Mr. Holton? Okay. What if there's any distractions in the room? What do you need to do? Eliminate them, right? If the radio's on, what do we do? Turn it on. Talk to him face to face, right? What else can we do? Do you speak loud? No. Slowly. Eliminate background noise. Directly to him. Speak loudly in low tones. But you don't yell. Don't yell at him. Okay? Alright. What safety issues would be appropriate to review with Mr. and Mrs. Holton? Foot inspection. What else? We went over it earlier. Temperature of the water. Wear shoes. Well-fitting shoes. Okay? Raven. So Raven mentioned this earlier. What do you want to get rid of? Carpets and rugs, right. And then what do we want to make sure, because he can't hear, but because of his decreased smell, what do we definitely want him to have in his house? Smoke detectors, right? Huh? Oh yeah, the flashing kind. But he has vision issues too, right? He's a hot mess. Alright, so a 70-year-old female presents at the eye doctor's office for an annual eye examination. She has worn glasses since first grade. She has severe autism, astigmatism, and photophobia. She probably has autism too. She currently wears bifocal glasses to enable her to see both near and far. She tells the nurse that she's having problems with seeing at night, mainly when driving. During the night, when she gets to go to the bathroom, she sometimes runs into the doors or walls because it's so dark. She does have some bruising on the arms and a scratch on forehead. What teaching would the nurse include in helping the client maintain safety at night? All right, let's go true, false. A, ask a family member or friend to drive you at night if you have to go out. Use a plug-in night light in your bedroom or bathroom. Yes.
Buy or rent a bedside commode and place it near your bed for nighttime use. No. Check. That's your key. Rent. Yeah, you wouldn't do that. No, that's not the right answer. Check that furniture or other obstacles are not in the path between your bed and the bathroom. Be sure that your bathroom floor has a non-skid surface and avoid using throw rugs. Use a large print digital clock on your bedstand so that you'll know when you go to the bathroom. Why? No. Be sure that electric cords or electronic device charging cords are not present between the bed and the bathroom. True. Alright, so now she, same lady, except however the client has beginning a cataract in his right eye, which requires surgery to prevent his vision from worsening. As part of the pre-op assessment, the nurse asks the client what medication he takes. He recalls most of it's fine. Maybe they changed what they want. He recalls most of his medication regimen, but the information is incomplete. Choose the most likely option for the information missing in the table. Okay, so look at option 1. You see option 1 at the bottom? Alright, Amipris, Apremilast, 30. Oh yeah, I do. Alright, so what do y'all think that drug is indication for? Look in option 1 down at the see contact dermatitis, hypertension, psoriasis. Y'all see that? Psoriasis, that's right. For real. Okay, so go to option 2. What is a second generation A1? Citrazine is number 2. Good job. See, it's okay. We in this together. All right. Option 3. Y'all know what that is. 40. Alright, Sildenafil, ED. Alright, the R word, what's its drug class? Good job, direct factor. Big X, little a inhibitor. Good. Alright, we got true false again. So this time, after the client's examination reports that there are no evidence of disease and his optic nerves are intact and healthy, he has a cataract and requires surgery to prevent his vision. He's scheduled for cataract removal and insertion of the lens. What pre-op health teaching will the nurse include? Alright. A. Check in with doctor about when to need to stop a few days prior to surgery. Yes or no? Yes. You will need to use eye drops to dilate your pupils and paralyze your eye muscles in the morning of surgery. True. I'm really not sure that they do that right before surgery, but before you go to surgery, you're putting drops in your eyes before you leave home. Right, be sure that someone drives you to the doctor's office and takes you home to stay with you for the first night. You will be on patient-controlled analgesic for the first 24 hours after surgery. No. E. You will need to wear dark glasses or sunglasses outdoors in brightly lit rooms several weeks after surgery. Yes. Your operative eye will have a bloodshot appearance that will fade over time. Yes. You may still need to wear corrective glasses or contact lenses after surgery. Yes. You will have to put several kinds of eye drops and or ointments in in our eyes a number of times each day for several weeks after surgery. Yes. So all but D. Alright, next one. A 68-year-old client just had a right cataract removal and insertion of that lens 4 weeks ago and is being seen in the doctor's office for a surgical follow-up. For each assessment finding, use an X to indicate whether the interventions were effective, ineffective, did not meet expected outcomes, or unrelated. Alright, so he had cataract surgery, now we're at the doctor. Has no bleeding or discharge from the operative eye. Effective. Operative eyelid is swollen but not red. 4 weeks after surgery. Ineffective. Vision in operative eye is improved. Effective. Reports new onset of constipation. Reports no sharp or sudden episodes of pain. Effective. Reports no flashes of light or floating shapes. Effective. Tearing eyes and nose from allergic response to pollen. Reports frontal sinus headache. Unrelated. Good. Okay. Last one. A 68-year-old male, he had his cataract removed. The nurse is preparing to teach the client's wife about the post-op care. Indicate which health teaching listed in the far left column is appropriate for the potential post-op complication. Not all choices will be used. Alright, so you see the far left, health teaching. So, what are you going to teach about increased intraocular pressure? Good job. Good job. Remind the client to avoid coughing, sneezing, lifting. Alright, infection. What are we going to teach about infection? What's another one? Infection. Contact the surgeon immediately if there is green or yellow drainage on the eye dressing when you change it. Y'all remember me talking about that? But what is normal? What's expected? White, creamy, crusted? Yes. Alright, hemorrhage. Very good. Observe the eye bandage. Eyelid swelling. That's right. And detached retina. If what? If they have severe pain or sees floating particles in the operative eye. Very good. All right.